Hopefully this is the right section. So we're going to be talking about motor systems today. I don't think it'll take the hour. I've tried to sort of distill it into the really key bits that come up in exams a lot. So as you can see on this slide, this hopefully looks familiar. This is the left-hand side of your syllabus. So this is just all the core content, none of the extra fun stuff. And everything in green is what we're hoping to whiz through briefly today. And as I say, yeah, it's the high yield stuff in exams I want to focus on, and thus I'm hoping it won't take too long, so you'll have time to have dinner early. This is a plan. So the three big things that come up a bit are so descending pathways through the spinal cord, then the basal ganglia and the cerebellum, and then I've popped in a bit about abnormal gaits as well, which is a little bit less common, but could come up. And I've got two Socrative quizzes, one on the basal ganglia and one on the cerebellum, featuring really the classic questions that are probably going to come up. There's just 5 of them. And if you're happy to do so, it'd be great to have you guys hop on and join in. They're just practice MCQs, which hopefully give you the advantage when it comes to the exam. So without further ado, we shall go on to descending pathways, the spinal cord. So the biggie is the corticospinal tract, which is the pyramidal tract. It mostly comes from the primary motor cortex, but also there's a little bit from premotor, supplementary motor and sensory areas. But the thing to remember is M1, and then it goes through the anterior 2/3 of the posterior limb of the internal capsule. So that's, if you remember your neuroanatomy, or you come to the session in a couple of days' time, that's between the thalamus and the globus pallidus and putamen. A cheeky one to remember for if you're ever asked about lesion questions, like strokes, is that the face is the most anterior of the anterior 2/3 and the legs are the most posterior. Then, as you can see on the diagram on the left, they form pyramids in the medulla oblongata, and most of them will decussate, that means cross over, to form the lateral corticospinal tract, and that controls the fine movements. Fairly obvious as they decussate in the medulla oblongata that if you have a lesion below the medulla, it's going to be you're going to see ipsilateral deficits, whereas if it's a lesion above the medulla, they're going to be contralateral, i.e. on the other side to where the lesion is. Some don't decussate and they form the anterior corticospinal tract, and they only cross over at the spinal level that they innervate, and that's your central axial and girdle muscles, so your big sort of postural stuff. And next we're going to focus on really all the other tracts, none of which are necessarily seen as quite so important, and thus don't quite come up so much as in exams. And you can sort of lump them all into the medial pathway and the lateral pathway. So the medial pathway, all of these ones are modulating the gross movement of your proximal limbs and trunks. So that's the stuff that keeps you upright, keep you moving. None of the fine bits and bobs. So as you can see on the diagram on the left, we've got the vestibular spinal, tectospinal, reticulospinal, and then also within this group, what we previously talked about, the anterior corticospinal tract. So the vestibular spinal tract, as the name might suggest, these are going from the vestibular nuclei, where you get input from the 8th cranial nerve, and that the vestibular nuclei, there's 4 of them, and they're sort of located over the lower pons and the upper medulla. These are uncrossed, there's no decussation, and they support posture and they maintain the balance of the body and the head. Then we've got the tectospinal tract, which flow slightly confusingly from the superior colliculus, which is also known as a tectum, hence the name. And the superior colliculus is getting input from visual nuclei, and that's located, anatomically speaking, on the dorsal aspect of the midbrain, so right at the top of the brainstem. Hence, tectum is Latin for roof. That's where the name comes from. And they do decussate in the brainstem, and as you might have guessed from the input from visual nuclei, these are coordinating head, neck, and eye movements. So that's helping your neck muscles and your eyes basically orientate towards a given stimulus. And then you've also got the reticulospinal tract, as the name might suggest, from the reticular formation. Hopefully it's all sort of, there's method in their madness when they when it comes to nomenclature. And that's coming from the reticular formation is numerous nuclei throughout the brainstem, none of which you'll need to learn. And that's uncrossed as well. And that's your anti-gravity extensors and axial extensors of movement. Oh, there we go. Okay. And then the other half is lateral pathway. So that's obviously the lateral corticospinal tract that we've already talked about, but it's also the rubrospinal tract, which is from the red nucleus, which you can see in the midbrain, which we have a sort of diagrammatic cross section of in the diagram at the bottom. Red nucleus, it sort of looks red. You can sometimes be asked about sort of what's going on down there, so worth being aware that it's sort of the big block in the middle and stuff. And they do decussate in the midbrain, and that's your flexion of your distal extremity muscles. So I mean, it is a bit of a broad separation, but you can sort of get this idea that the lateral pathway is the sort of distal muscle. It shouldn't say distal limbs, it should really say distal part of the limbs. But these are your sort of precise movements, and this is your distal muscles, as opposed to the medial, more proximal stuff. So that is sort of the spinal cord summarized very briefly. I think one really key thing that can occasionally be a little bit funny to wrap your head around is being able to differentiate between upper motor neuron and lower motor neuron lesions. And this is the sort of stuff that does come up in exams, and is also very, very useful when you hit your clinical teaching later on. So an upper motor neuron it's a bit of a misnomer really, but that's sort of everything we've just discussed. So it's all these neurons coming from the motor cortex and out, as opposed to your lower motor neurons, which are going from the thing that the upper motor neuron synapses into out to the periphery. So your examples of your lower motor neurons would be your cranial nerves, which are projecting from brainstem nuclei, but also your spinal nerves, which are from anterior horn cells. So we'll start on the right. So lower motor neuron lesion. That's really the obvious stuff, exactly what you'd expect if you had a problem with the nerves communicating with muscles. So the muscles are going to be flaccid. They're going to have these random twitches that we call fasciculations. Your reflexes are going to be decreased. You're going to have atrophy, which means the muscle bulk will be reduced. And they'll be Babinski negative, which means if you're a very grumpy neurologist and you scratch the bottom of someone's foot from the bottom up, their toe is going to point down, so towards the ground. Whereas conversely, you have your upper motor neuron lesions, and these are sort of the things you wouldn't necessarily expect. You know, there's a muscle problem, yet the muscle is spastic. You have this clonus, which is this sort of rhythmic, very large jerking. Your reflexes are still often decreased, but there's only a slight loss of muscle bulk, and you'll be Babinski positive. So you scratch along the bottom, and the toe points back up to the head. Moving on to, I think, where the motor course sort of gets interesting, we've got the basal ganglia and then the cerebellum. So the basal ganglia, hopefully this all looks familiar. It's all this stuff in the diagram on the left. And the most important thing to remember about the basal ganglia is it's releasing a motor program. That's the way to think about its function. And as I'm sure you're all aware, it's a little bit more complicated than the diagram on the right suggests, but this is a nice, simple way of thinking about it, and is perfect, more than acceptable for sort of part A knowledge. We'll move on to the next slide because the diagram's still the same. And we're going to run through over the next few slides the different neurotransmitters. But just to look at this diagram, just sort of pick it apart, you've got this so the input from the cortex, but it's the striatum that's really driving this big direct pathway straight to the globus pallidus internus and substantia nigra pars reticularis. And then you've also got this indirect pathway. And once you get to the GPI and the SNR, they're then projecting out to the thalamus, and they're the guys that are sort of releasing this motor pathway. And you've got this slightly funky sort of regulatory stream from the SNC and the VTA, the ventral tegmental area, coming back to the striatum and inputting on D1 and D2, but that's 2 slides time. So keeping with the most obvious neurotransmitter, there are classically questions in exams like what's the predominant action of glutamate as a neurotransmitter? So the answer is excitatory. And the major glutaminergic sort of projections, bizarrely shown in red on this diagram, are from the cortex to the striatum, and then also from the subthalamic nucleus to the internal globus pallidus. And as you might be sort of able to decipher, if you're getting a lesion in the STM, the subthalamic nucleus, you can end up with this ballism, which is when you have these very violent involuntary limb movements. And you can see here, effectively what you're getting is this aberrant release of motor pathways, causing these limb movements to occur. But I think the quite nice thing about the basal ganglia is when you start to figure out how it works, then you look where the lesions are, you can sort of decipher what the symptoms might be. I find that quite pleasing. Anyway, we'll move on to the next neurotransmitter. So that's GABA. Hopefully that's familiar with like the predominant inhibitory neurotransmitter. And the major GABAergic projections are from the striatum. And so these are, I should say, these are in black on the diagram. So that's from the striatum and the internal and external globus pallidus. And the way to think about this really is, I suppose there's a general brake, a GABAergic brake on the release on motor pathways, and then you have this sort of excitatory release of the brake and drive of the accelerator, and that's what you can sort of see here through the direct pathway, which is predominantly sort of the striatum saying, well, hang on, the basal ganglia saying, let's not release this motor action, and then that sort of brake is taken off. That sort of, I don't know if that makes sense, but hopefully it does. That's sort of the way to think about all this, and you can have a problem, involving these GABAergic neurons in the striatum. Is Huntington's chorea. So chorea meaning dance-like movements. Probably guess the symptoms. It's these jerky sort of movements. And hopefully you remember from the lectures that this is when you get these repeats of CAG in the Huntington gene, and over 36 is seen as pathological. But the more you have, the earlier the onset of Huntington's. And Huntington's is one of these really nasty things where often it presents after the age at which people have had children, so it didn't then impact their decision to go have kids, and then they feel very guilty about passing it on. And it's a bit of a, well, there are no nice diseases, but it's a bit of a nasty one really. But from a functional point of view, it's degeneration of these striatal neurons. So then if you sort of work your way down the little diagram, so if you've not got striatal neurons, you've got decreased inhibition of the globus pallidus externus, and then that's going to conversely increase the inhibition of the STN, which then decreases the inhibition of the thalamus, which then means you're releasing these brakes on these motor pathways, and you end up with the jerky movements. That sort of sounds quite complicated, but I think when you look at the diagram on the left, you can sort of work your way through it quite logically. And the last big neurotransmitter we're going to talk about with regards to the basal ganglia is dopamine. So your major dopamine, that's in grey on the diagram, and your major dopaminergic projection is from the substantia nigra pars compacta to the striatum, and then you have two different types of dopaminergic receptors in the striatum that these dopaminergic neurons are projecting onto. You've got D1 and D2, and as you can see on the diagram, your D1 receptors, dopamine acts and it activates this direct pathway, which is inhibitory, this GABAergic pathway, whereas D2 receptors inhibit the direct pathway. So it's the same neurotransmitter having two different effects. And where can that be a problem? Well, the classic disease that is an absolute exam favourite is Parkinson's. So a classic question would be sort of, where is the degeneration in Parkinson's? It might just be a question like that, and you have to click it, or it might be a diagram. And the thing to know about that is the substantia nigra is called the substantia nigra because it's a black area in the brainstem. So sort of there's an arrow to a black area. They're talking about the substantia nigra pars compacta, and there's probably going to be Parkinson's questions coming up. But yes, Parkinson's degeneration of actually dopaminergic neurons in various places, but classically we think of it in the SMVC. And the symptoms you get are known as TRAPS, that's T for tremor, R for rigidity, this cogwheel rigidity when you rotate their wrists. They have a sort of akinesia or bradykinesia, so reduced movements, and postural instability. You're classically thinking of the little triangular warning signs that say, old people slow down on the road. That's the sort of Parkinsonian image that should sort of conjure into your mind, the classic image. And how do you treat them? Well, you give L-DOPA. So that's one of the points on the syllabus. So you want to increase the dopamine. Well, ideally, you want to regenerate these neurons, but we can't do that yet, unless sort of mimic their action with deep brain stimulation, but mostly we're looking to sort of boost the function of the neurons that are there. And so we give them the dopamine precursor L-DOPA, because L-DOPA can cross the brain barrier, dopamine can't. And then we also give a DOPA decarboxylase inhibitor, which then stops the breakdown of dopamine. So you're sort of supercharging the remaining neurons. But obviously the sad thing is you're not stopping the destructive effects of Parkinson's. So in the end, those drugs will stop working. We've now got a little quiz, if you're feeling up for it. It's only 5 questions on the basal ganglia. Hopefully you're all familiar. I've been promised you're all familiar with Socrative. So I haven't put the right code up there, but the maybe I can put it in the chat. But the thing you've got to enter on Socrative is Brockwell 4802. So I'll pop that in the chat for everyone, so you have access. And really, if you're finding me talking very unhelpful, hopefully this is genuinely helpful, because these are all, I asked around, these are all questions that people can sort of remember being on the exam. So hopefully be useful. Brockwell 4802. There you go. So I'll give you a minute or two to sort of hop on that. In fact, I'll stop sharing for a sec and let you all pop on there. So as I say, only 5 questions. Oh, marvelous. Yes, brilliant. Okay, so Parkinson's disease, first question, Parkinson's disease, where do you expect to see the loss of neurons? Substantia nigra, pars compacta. Yeah, someone put the pars reticularis. Yeah, it's just a rote learning section, I'm afraid. But yeah, pars compacta it is. Question number 2. So question number 2 is, what is the main neurotransmitter used by medium spiny neurons of the striatum? So that's sort of the main output of the striatum. So okay, the split 70-30. So yeah, they're GABAergic neurons and medium spiny neurons. So worth sort of making a note of that. I'm afraid all these questions are a bit grumpy, aren't they, really, because they don't involve you thinking and coming up with a brilliant answer. It's sort of rote learning, but unfortunately that's sort of what part A is more, and then part B is where you get to write your lovely stuff in the essays. So we'll move on to question number 3. So question number 3 is, in which nucleus might you see neuronal loss in Huntington's chorea? Okay, so a bit more of a mixed picture here. So it's actually the striatum where you see the neuronal loss in Huntington's, and I think we sort of went over that. So that's your loss of your inhibitory neuron. So it's a loss of that break, and that's why you're getting those that sort of chorea, that the dance-like movement that you see in Huntington's. Question number 4. So this should say pathway. So the nucleus involved in the indirect pathway, but not the direct pathway. Okay, fantastic. There's a sort of clear answer coming out there. Well done, guys. That's absolutely, it's a subthalamic nucleus. That's a sort of nasty question you can get asked, and it's a bit, I guess it's quite frustrating at your level, because you're like, oh, this is just a sort of rote learning exercise. But that's why the simple diagram that I posted, as I say, there's actually far more connections to that, but that simple diagram is just worth learning, because it means then suddenly any question on the basal ganglia, you're just getting 100% on, and it becomes really easy. And question number 5, so that's damage to which nucleus would you associate with Ballisms? So damage to which nucleus would you associate with ballisms? As I say, these are all questions that we could sort of remember being asked in either practices or our exams. But I try not to include the really easy ones. So some of these are nastier. So if if you're not getting 100%, don't worry. I've picked the slightly more horrid ones. Yeah. Okay. Brilliant. Okay. So most of you've answered that. Yeah, that's a subthalamic nucleus. So they're my 5 questions there. So we'll come back in a sec for the cerebellum questions. That give you hopefully a bit of exam preparation. Okay, so that's all I've got on the basal ganglia. Let's go. Come on, pop up. There we go. Okay, sorry. So that's that. So moving on, cerebellum. So what does the cerebellum do? So I've written it in the bottom left. Motor coordination. That's what you think of. So it's this sort of calibration of movement. So it's not the selection so much as sort of the modification of your movements. And it says in your syllabus that you need to know about the 3 lobes. So you've got the anterior lobe anteriorly, the posterior lobe posteriorly, and then the slightly funky floccular nodular lobe, which is this sort of funny bit that's hanging around at the back. And if you see, the only other thing to know about, if you see a cerebellum on CT, the bit at the bottom that sticks out, if there's ever an arrow pointed down, they're known as the cerebellar tonsils. And the only reason that's relevant is you can have something called a Chiari malformation, which you don't need to know about, but basically it can drop down through the foramen magnum, like the whole of the bottom of the skull. I haven't included a picture of where the cerebellum is on the brain, because hopefully we've all got that. It's a sort of fluffy thing right at the back. So this is a cellular view. It's a horrid image, isn't it? But we can sort of work through it and decipher it, I'm hoping. So you've got your Purkinje fibers. So your Purkinje cells, sorry. So that's your green thing in the diagram on the left. And they're your sort of big thing to focus on, because they are the sole output to the deep nuclei of the cerebellum. They're GABAergic. So this is an inhibitory output to the deep nuclei. And then everything else sort of links in one way or another to these Purkinje cells. So the simple routine is we have these mossy fibers, which you can see in sort of bluey purple on the right of the diagram, which synapse with granule cells, and then those granule cells synapse with Purkinje cells, and they do so via parallel fibers. That sounds slightly confusing, but if you look in the diagram, we've got the purple mossy fibers linking to granule cells. Granule cells are those parallel fibers with the 2 lines across the top, and they're then synapsing with Purkinje cells. And each Purkinje cell has input from thousands of parallel fibers. And it takes input from an awful lot of these parallel fibers to form a simple spike. And that simple spike causes a Purkinje cell to signal. It's GABAergic. So this is an inhibitory signal which inhibits output nuclei. And what that does is it offsets motor inaccuracies, thereby calibrating the motor response. So the way I always think about this is, because it's the test we do in clinical medicine, is you're asking someone to touch their nose and then reach out and touch your finger or touch an object, and they're wavering about, but they're getting closer and closer to the point, and that's sort of what you've got, or they're sort of moving around and up. That's what we're doing here. It's the cerebellum going, oh, hang on, you've gone a little bit too far this way, that way, the other way, and we're shifting you in. So it's why you've got this inhibitory output from the Purkinje cells. However, the cerebellum also plays a role in learning, and that's where you have these complex spikes. So this is input from a climbing fiber, which you can see in red, onto the Purkinje cells, and that causes long-term depression of the parallel fiber Purkinje cell synapses. So that's where the granule cells are synapsing onto the Purkinje cells. And that's thought to play a role in motor learning. Has any of you written a Part B essay on this? This is sort of a slight simplification, but this is sort of what you need to know for the exam. So you've got your simple spikes, which are offsetting the motor inaccuracies, and then your complex spikes, which are all about this learning of correction of motor pathways. And then you've got 2 other funky cells doing other stuff. well, actually quite a few other cells doing funky stuff, but the two you need to know about are basket cells and Golgi cells. And these interneurons help with localizing the stimulus. Because you've got all these Purkinje cells synapsing onto, all these granule cells forming parallel fibers and synapsing onto the Purkinje cells, what you can end up is a sort of a broader, or you could end up with a broader signal being sent that you want. So what basket cells and Golgi cells do is they really try and reduce that, really trying to sort of fine tune the stimulus temporospatially. So it's the basket cells that are doing so sort of spatially. So they're reducing the activity of nearby Purkinje cells. So it's only the Purkinje cell you want, you shouldn't say you want, but only the Purkinje cell you want firing to actually fire. And then Golgi cells are reducing the duration. So that's the temporal limitation, the time limitation. So they're saying of granule cell excitement. So they're saying, you fire and then you stop. If that makes sense. Hopefully that sort of decoded the cerebellum. Unfortunately, those bits on the right, hopefully it's not too much text and it's all sort of, bringing up memories of what they'd covered in the lecture. But that stuff on the right, that should be sort of your way to get 5 out of 5 on a cerebellum question in a Part A exam. So then these are those deep nuclei that I was talking about. So there's 4 of them, but you can split them into 3 groups, confusingly. So you've got your medial nucleus, which is a vestigial nucleus, and that's that sort of signaling via the vestibular and descending spinal systems. Then you've got your intermediate nuclei, which are globose and embryolliform nucleus, and they're signaling via the red nucleus, which we mentioned before, and descending spinal systems. And then the slightly funky one, which is the lateral nucleus, the dentate nucleus, which has a sort of thalamic relay via the ventral anterior and ventral lateral thalamus up to the motor and premotor cortex. And if any of the stuff on the right-hand side of that slide is looking a little bit confusing and shaky, we do have a neuroanatomy lecture, I think tomorrow or the day after, where hopefully we're sort of covering what that all means. So I shan't sort of recount it now. And of course, you can have problems in the cerebellum. Not generally, it's not such a classic question as the sort of the 3 diseases that we talked about in the basal ganglia. But given the fact that we know it's this in the cerebellum, it's modulating this motor response. If you have a lesion, you lose that calibration. And the classic 4 symptoms are the 4 in orange here. So you get nystagmus. I don't know if you've heard about that, but that's that sort of involuntary flickering of eye movement. You have incoordination, postural ataxia, so sort of difficulty standing. I'm slumping now, but it is difficult keeping yourself upright, and an intention tremor, which is when you're trying to reach for something, but your hands sort of wiggling around as you start to make that move. So we've got 5 questions now on the cerebellum. Again, they're all taken from asking around friends what we can sort of remember from our exams. So if you just give me 1 sec, I need to get the new quiz up. I'm not a whiz at Socrative, I'm afraid, so it's going to take me 1 sec. Okay, so hopefully now, if you type in Brockwell 4802 again, it should come up with the cerebellum quiz. Or if you stay on the same thing, it should work, and just refresh the page. Brilliant. Shout that out in the chat if that's not working for you, but it seems to be working for other people. So, amazing, guys. You're doing a brilliant job. 100% on the first one. Absolutely right. Purkinje cells are the major output neurons of the cerebellar cortex. Absolutely brilliant. Right. Next question. How about this? Mossy fibers synapse onto which cell types within the cerebellar cortex? Yeah, it's a nasty question, but mossy fibers synapse onto granule cells, and then it's a parallel fibers of those granule cells that synapse onto Purkinje cells, which is a bit lumpy, I know, but that's the way to remember it. But I say that's all in that diagram with that passage of text. Let's move on to question number 3. It's just a true/false. So this is the cerebellum has motor effects on the ipsilateral side of the body. I suppose the question really here is it ipsilateral or contralateral? Brilliant. You've all gone for ipsilateral. Absolutely fantastic. Yeah, it's a bit confusing, but yeah, cerebellum is ipsilateral. What about question number 4? So this is in neurotypical adults, the molecular layer of the cerebellum does not contain. So I didn't mention this specifically when I talked about it. I should have done, really. Maybe we'll pop back to that slide for a sec. But there are 3 classic layers of the cerebellum, and which one does it not contain? This came up in our exams, and that's why I put it in, because I didn't know the answer. I was very upset. So, so it's actually mossy fibers that it does not contain. And last but not least, question 5. So a patient's arm shakes as they reach for a pen on the desk. The shaking increases the closer they get to the pen. A cerebellar lesion is a probable cause. Obviously, there could be lots of things causing this, couldn't there? But absolutely right, 100%. Well done, everyone. A cerebellar lesion is absolutely a possible cause. Absolutely. So that's the end of that quiz. Well done, all. That's looking very, very promising. So we'll just very quickly pop back to that slide, because I did omit to mention, which is terrible of me. Yeah, so here you go. So here are the 3 classic layers of the cerebellum, the 3 layers of the cerebellum. So yeah, it's just worth being roughly aware of the ordering. So you can see in your granule cell layer, that's sort of the bottom layer as such, that's where you've got your mossy fibers synapsing, and the Purkinje cell layer, that's where you've got a lot of you've got your Purkinje cells. That's a bit of a classic, isn't it? And then the molecular layer is where you get a lot of those interneurons, and it's where you're going to be having all the synapses from the parallel fibers. So it's a bit of a funky system if you think about it, because you've got sort of, it's in a way the cerebellum is projecting sort of top down, if you want to think of it that way, because you've got the parallel fibers at the top coming from the granule cells coming down through the Purkinje cells, synapsing onto cerebellar nuclei in the white matter. Anyway, we're very nearly almost done. So as promised, we've almost made it. So the very last slide is just a slide on abnormal gaits. So I wasn't initially going to put this in, but then I thought it is an absolute gem of an exam question if you get it, because if you know the answers, it's super simps. But in the stress of an exam, I know it could be very, very hard to think and get your head around everything. So this is just in one slide, last slide, sort of as such, everything you need to know. So if they're talking about small steps and freezing, we talked about Parkinson's. Obviously, as you now know, it's problems in the basal ganglia. So this is difficulty releasing a motor program. So that's where you get that freezing, i.e. difficulty releasing a motor program, difficulty initiating movements. And we talked about one of the symptoms being akinesia or bradykinesia, so there's reduced movements, and that's where you get sort of shuffling steps as well. A different type of gait is where the feet are slapping the floor. And if you think about it, if your feet are slapping the floor, well, the only time I do that is when I've not looked at the floor and then get slightly muddled about where the floor is in relation to my foot. So that's to do with absence proprioception, which is sort of your awareness of your body in space. There's some sort of problem with your body figuring out where your limbs are, I guess. And 2 classic causes of that, obviously peripheral neuropathy, so a problem with your peripheral nerves, or you can have, it could be a complication of syphilis, which we weren't seeing for a very long time, and then now syphilis is on the rise again. And another gait, a limping gait, can be one cause of limping is hemiplegia. So that's a paralysis of one side of the body. That's, you're thinking about a problem with the motor cortex, or as we talked about, the internal capsule. I mean, obviously there are lots of causes of limping, but that's just one to know about, although sort of the one that's mentioned in the syllabus. And there I shall leave you. As you see here, if you've got any questions, do email me. That could be scary to start out the lecture, but probably easiest to email me, and I'll do my best to get back to you probably tomorrow afternoon. If you have any questions about the course, there's the general lecture there, and if you could complete any feedback, I believe that means you get a copy of the lecture handout. And I've really tried to put, I know they're very content heavy slides, but I was trying to do that so even if I've been talking and it's been very boring, haven't listened to it, you can at least have a read through. They can act as a sort of half decent revision strategy, because I know you have very little time to quickly look through your notes in between the Part B and the Part A exam. But hopefully that's been helpful. Thank you very much for coming, and I shall see hopefully some of you tomorrow evening. Yeah, for those of you who have asked for the link, hopefully hopefully I've just sent that, but do shout out. And everyone else, go and look after yourself, and have a cup of tea and a nice dinner, and maybe I'll see you tomorrow. Or if you really haven't enjoyed it at all, then I won't see you tomorrow, and that's okay. I'll take that as good enough feedback from about my lecture.